Hi there. My name's Kabriya, and I'm a PhD candidate at Sick Kids in Dr. Hamilton's lab. I'm going to be talking about a functional assay. So we're developing a functional assay to diagnose catecholaminergic, polymorphic ventricular tachycardia and heart failure patients at risk of developing ventricular tachycardia. Next slide, please. So what is CPVT and what's the pathophysiology exactly behind it? So CPVT is a rare arrhythmogenic disorder. It is characterized by abnormal heartbeats, and episodes can be triggered without any structural abnormalities found in the heart. So the exact prevalence of this disease is unknown, but it is predicted to affect about 1 out of 10,000 people. So events can be triggered by sympathetic activation, which means some type of physical activity like exercising or emotional stress. The most common mutation found in more than 60% of the cases is found on the RYR2 gene, which encodes this ryanodine receptor 2. This receptor is actually an intracellular receptor found on the sarcoplasmic reticulum, and its main function is to control calcium release into the cytosol to do downstream signaling or functions. And most commonly, we end up with the gain of function mutation, which results in leaky calcium channels. But recently, patients were also found with a loss of function gene as well. So either this receptor will have the mutation or other proteins associated with this receptor will have the mutation. However, the end result is always a malfunction in the amount of calcium that is being released. Next slide, please. So currently, diagnosis is done by doing something called an exercise test. It's the primary diagnostic method for patients by making them exercise as a means of adrenergic activation to see if there's any ventricular tachycardia. Usually a positive test is highly accurate for these to predict CPVT. However, a negative test isn't sufficient to rule out whether these patients would have CPVT. When testing was done, about 13% of people who got a negative test ended up with observable cardiac events like syncope or even cardiac arrest later on. So more accurate and additional diagnostic tests must be developed. So to do that, to actually start with it, this ryanodine receptor, there's 3 isoforms. Ryanodine receptor 1 is found in skeletal muscle, 2, the one which we're looking at, is found in cardiac muscle, and 3 is predominantly found in brain tissue. So to assess this receptor's function without being invasive, we found out that another cell also commonly expresses RYR2, which is the T lymphocyte, which is found in blood. So we decided to extract these T cells from patient blood and run our analysis on that. So using flow cytometry and its microfluidics, we're assessing the sensitivity of the RYR2 receptors in patients to a well-known stimulant called caffeine. So depending on the amount of calcium being released, we'll determine whether this patient has a loss of function or a gain of function mutation. Next slide, please. Next slide, please. Oh, sorry, thanks. So how are we going to assess the receptor functionality? So using the common stimulant caffeine, we will stimulate this receptor, and we will use the couple methods to determine its functionality. So to measure calcium, so to do calcium measurement, we will be using flow cytometry, which is an ideal method to simultaneously measure calcium flux and also identify CD3 positive T cells. So these T cells will be bound with CD3 antibodies, which are conjugated to a fluorochrome, and cells will also be loaded with fluoride dye, which is a calcium indicator dye. So this dye basically enters the cell, and it's conjugated to AM esters, and then once it gets into the cells, the AM portion is cleaved off, not allowing the dye to exit the cell. After that, when we're giving the caffeine stimulant, it will be able to bind the calcium, and using a ratiometric calculation, we'll be able to determine the concentration of the calcium that's present. Also, we'll be assessing metabolic function by doing an ATP assay, which is like a luciferase assay on cultured T cells from the patients to evaluate the amount of ATP production that's here. Essentially, more ATP, we're thinking that more ATP will be used up in a gain of function situation. And we will also be measuring the intracellular pH, either using a proton assay or using a pH indicator molecule like SNARF. So basically, these 3 methods will be evaluated to see which one will be the most optimal method to assess RYR2 function, so that a functional assay can be developed or standardized across clinical labs to aid in the diagnosis of CPVT. Thank you.